morning and good afternoon, and welcome to today's event on virtual reality in healthcare. My name is Jonas, and I'm the Deputy CEO of Swissnex in Boston and New York. At Swissnex, we have the privilege to engage meaningfully with incredible stakeholders in our extended backyard and to meaningfully connect them with Switzerland's education, research, and innovation stakeholders. Today's event stems from a collaboration with the Board of Higher Education of the Canton de Vaud, which is one of our longstanding partners. And as part of this collaboration, we work with some of the canton's higher education institutions. And for this series, we have the pleasure to partner with HESAV, the School of Health, which has longstanding ties to the greater Boston area. And while at this time, no HESAV community member is able to come to Boston, we have the pleasure to launch a brief series of insights from the frontiers of healthcare as we experience them in the greater Boston area and beyond. And today's topic is on the intersection between virtual and augmented reality in healthcare. And to introduce you to our wonderful speakers and to navigate you through our next hour, I now have the pleasure to hand it over to my colleague, Johanna Lemon, who is our wonderful events and operations manager. Johanna, take it away.
Lemon, and I am the events and operations manager here at Swissnex in Boston, and I will be your guide to today's discussion. I would like to introduce you briefly to our two speakers. Gentlemen, if you could join me on stage for a moment. We will be speaking with Dr. Brandon Birckhead and Jan Fossat, both of whom are fervent believers in the power of virtual reality technology within the field of healthcare. But first, the format of our talk today will go as follows. We will begin with Dr. Birckhead and then have a discussion with Monsieur Fossat. We will then follow both talks with an audience-driven Q&A session. We would highly encourage you to input any questions you have in our Q&A section on the Zoom webinar function throughout the presentations. But please remember, insert them in the Q&A box and not the chat window. Jan, we will be seeing you a little bit later, but for now, if Dr. Birckhead could stay here, we will start our conversation with him and allow me to introduce you to him. So, Dr. Brandon Birckhead is what you might call a Renaissance man. After earning his medical degree at the Mayo Medical School, he's currently looking to pursue a residency in psychiatry at Johns Hopkins University. And if that weren't already enough, he's also the host of the Immersive Psychiatry podcast, which spent its first season discussing how mental health and immersive technology can intersect. I'm sure he says this enough, but be sure to subscribe. Suffice it to say, Dr. Birckhead's passion and his career have centered around the usage of VR or virtual reality technology. In 2016, he examined how it could decrease pain and anxiety in dentist offices. Later, he worked at the Medical College of Wisconsin to develop a program that used VR technology to help breast cancer patients familiarize themselves with radiation treatment. He was also a member of the Virtual Reality Clinical Outcomes Research Experts Panel, or VR Corps, and worked with Dr. Brennan Spiegel at the Cedars-Sinai Medical Center to explore the use of at-home virtual reality technology. Dr. Birckman, it's an honor to have you here, and the floor is yours.
Thank you. Thank you so much for that intro. Let me just get my screen up, and great. Hopefully this works through there. So today I'm going to try to attempt to give an introduction to the use of immersive technology within healthcare. And so yeah, let's start off a little bit about my experience, just so you know a little bit about how much kind of where I'm at within this very large landscape, and then try to give you some inspiration for getting involved in what comes next, whatever you want to get interested in. So I'll start with my first year. So, I try out VR. Friend was developing his own kind of independent game. Loved it. Thought it really had some really impactful effects to be immersed in a virtual world. And this is maybe something that it would be akin or helpful for you all. I was still, essentially a medical student, becoming a resident, had no grant funding. I essentially started off with a bucket of ice and trying to assess pain levels in a safe way, which was with bucket of ice. And using off-the-shelf VR programs, because again, I had no grant funding. That started off with just like essentially testing a few things with my fellow residents, with an invite of pizza. But that actually evolved to me actually taking some of the studies I've seen, and this is a great tool for you all to use if you get interested in research, is maybe your first couple studies, if you've never made one before, try to copy the best design you've seen out there when you look into the literature. And then you can take more modern technology, as I did here, if it's a study of 10 years old, but a great design, and recreate it. And so I worked with some of my colleagues back at Mayo Clinic who were happy to execute the study, and they did a fantastic job. And so that was my first study, was actually look at how could we help with potentially in areas where you maybe don't have access to pain medication. VR has been shown in a few papers to help with acute pain, and has been used in some resource limited areas by providers. So that was the first year. The second year, I started going into radiation oncology. So it's a different field than I'm heading in right now, but in there, a lot of challenges related to how would you help a patient understand why you would irradiate their breast that might have cancer. It's a challenging area to overcome that might be help the visualization. So I actually designed a study basing it off of a comparison for just a video. And it was a great design. I feel bad because of COVID, we got $40,000 worth of grant money, but the time frame just didn't work out due to what happened eventually by the time the grant actually got initiated. But it was a great design, and definitely a lot of great work happening with patient education, and really Jan's got some great work with patient education. The other thing that's probably useful for you all is that I did work with a group that we collected together of researchers to discuss methodologies. So research methodologies are helpful for a new field. And how we modeled this was a little bit off of what happens with FDA studies, in that the main difference though for VR is building that first developmental study with patients using human-centered design. So each patient population may have a different needs, wants, desires, background. And given that this is a cognitive intervention where it requires engagement, that's critical that you understand these components when you're actually implementing it. And the other two, VR2, VR3, these are what you probably would see if you go look in the literature, early stage studies, testing feasibility, and then later, gold standard randomized controlled trials. A great experience that I had. The next several years, I actually switched from radiation oncology, kind of going full force into research for VR, and trying to attempt my first year out with Cedars to do home-based self-administered VR, essentially onboarding patients even over the age of 70 or 80 with VR over the phone. And we learned a lot from this study. It was a trial and error process to be the first to do this. But we learned enough from that we actually implemented it in a government-funded study. And all the learnings that we got from that initial at-home study, we put into this. And this is a 5-year study. It's ongoing. It has over 25% of the population has already completed it. 2 months long. You get VR at home. Again, we ship it by mail. And in this one, the key is we have 3 groups. So one is a sham or placebo VR, which is essentially a floating TV screen. I used to use these in dental offices. So I thought they would make for a great control to just be a 2D version of content. This is non-engaging, not necessarily fun content. The middle arm is kind of 360-degree video, which we know is good for distraction, but probably not great for long-term chronic pain, where you really need to learn a set of skills. And so we call this like skills-based VR. And so you'll see here several skills that are taught over a 56-day period. So I'm very interested to see how the results of that study. I'll probably get those results by the time I finish psychiatry. In the meantime, though, there actually has been published work by the vendor. I helped them come up with a clinical trial design so that they could do a study. This was actually through Facebook. So this is any user across the US. It recruited everyone, 188 people in 2 months. I was amazed. And we actually able to publish that. And this is where we take something just like that placebo, that sham, non-engaging VR versus the skills-based VR, and showed statistically significant results for pain interference and and also for physical activity and sleep disturbance. So going forward, I'm going into psychiatry mainly because there's so much that can be done in this space, particularly within the mental health area. And so in my meantime, I am making a podcast to help kind of solidify where I've been and how that might inform my future or the future that could come with the field. All right, now here's the big part of or the hard part of the presentation is the landscape. So I tried to do my best. I'm a lumper. I lump things, and it makes things somewhat easier, but it's hard with an evolving intervention. So trying to make some groups that I think I'll be happy with in 5 years that it still works for lumping. So I essentially have everything in 4 groups. One is education, another one is therapy, another one is diagnostics, and then practice augmentation. And this is just a picture here of the FDA did do a workshop a little bit pre-pandemic. And so there is a lot of interest in the FDA. There have been applications submitted for VR, different types of VR indications. So things are moving within the field. The hardest one of these groups that probably I need to describe as far as, how I'm making that bucket is augmentation of practice. And so what I mean by that is anything you're doing in your day-to-day life within your clinic that could be enhanced by either VR or AR. And so in this case, we see here a surgeon who's putting in like a catheter and using the medical images embedded anatomically correct on the patient to help with that procedure. This is a huge area of research, mostly for the surgeons, of course, and the proceduralists, but very fascinating area that has had some good work in. The other one, which is probably something more that I'll be working on with research and within my future field, is the use of VR for telemedicine. And so I have a colleague at Vanderbilt who has developed a platform to do peer support. And so this is a program called Help Club. You can actually find it on the App Store if you look on Oculus App Store. It's very interesting to see how people can come together and support each other in a virtual environment. And so I conclude that in this augmentation of how we will interact. All right, education, I split that into providers and patients. Jan's got some great examples for patients, so I'm not going to go over that in detail. For providers, what I would say is, if you look at it, so the one we have here on the left, I believe this is a research this is a clinical trial that's ongoing in Europe. Not exactly sure where right now, but what they're teaching is ECT. So again, for psychiatry, they do something called electroconvulsive therapy. There's at least 20 steps you got to follow to go through the whole procedure. And so in here, they're teaching people step by step that checklist manifesto that you have to get into your head, do it in an interactive way. Usually provider-based education is more detailed than I would say patient education, but it depends on what the goal is. For patient education, it's usually either directly helping them with some type of disease management or teaching them about a procedure like what I did for radiation treatment a few years back, or what they're doing here in this picture, which is helping a patient understand their ECT or electroconvulsive therapy through a 360-degree video. Diagnostics is a very fascinating and growing area. Probably the best work I've seen in this has been for dementia. And so I actually participated in a study where they just asked gamers. So they had a program called Sea Hero Quest VR. And I was, I guess playing that game or being a participant a few years ago, but they had thousands of gamers playing this game. And it helps to understand where you're at in this map. And so geospatial understanding is a cognitive skill that can decline with cognitive decline. And so I was involved in that, and they were using that to get a baseline from the population that they could then use as part of an assessment in the future. And there's other labs working on cognitive decline related assessments in VR. The other area that has gotten some traction has been ophthalmology. So of course, the thing about head-mounted displays is they're right in front of your eyes. And so they can help with assessing, doing self-administered eye exams. And so that's another area of the field. Treatment is really where I've been focused since I started. So treatments, there's a lot in this area, and you could break down some of the bigger buckets. Maybe, you'll have pain reduction, which is an area that I've worked on, either chronic pain or acute pain, acute anxiety. Another one is physical therapy. So we have on here On the left, we have, I think that's Fruity Feet. I forgot, but it's my colleagues at Stanford that did a great job making their own study. And they actually have done some papers on this as well. And so that's helping kids to move. So physical rehab is a huge area, lots of randomized control trials, as well as some lots of pilots actually. And the other area is mental health. That makes up probably 50% of the treatment related publications. And the classic example, the first publication was in phobias. And so what we see here on the right is a group that did a really cool study where they had a VR for heights. So they actually have someone's neighborhood and you're walking kind of at this big plank above that neighborhood. And then to test it, they actually took them to an actual tower and had them stand at the tower. It's showing good results when doing that in comparison to baseline, CBT for phobias. More of a desensitization process, but lots of great literature for phobias. But you can almost pick any disease in the DSM, and there's probably some work in that area using some immersive technology. Also with virtual humans is going to be a big thing in the future. They're using that for a lot of skills-based related studies. So this would be a study that was done with autistic patients who have a hard time with interviews where you may need to do a lot of face-to-face eye contact. So they were using that as an occupational training program. Fascinating stuff out of University of Southern California. All right, time to get you all inspired and get you interested to maybe get into the field. So what's the future of everything? Well, there's probably a lot that's going to go on in the future. Some things will be when your smartphone turns into a pair of glasses. A lot of the big phone makers are working hard on patents for augmented reality phones, or glasses, I should say. That will have a lot of implications for healthcare. The other area that I'm interested in right now and probably will contribute to in the future is precision VR. So this is using kind of individualizing the VR experience to the patient. I'll have a podcast on this probably in about a month or less. So you'll learn more about that. And then care at home is really the mission of all of digital health. The biggest thing for digital health is how can technology bring care to the home, bring treatment, understanding, triage, diagnosis. It's a long-term play, but it's where everything is going, and it's an exciting area. Embodiment therapy is very unique to VR. I know I don't have a ton of time, but what I would say is this pictures here is that if you have a virtual avatar and you can track your whole body, the brain will attach itself to a virtual body when it's linked in a very specific method. And you'll see this in a few studies. You're actually closer to this lab than I am now, but there's a lab in Spain by Mel Slater, who's world renowned for his work in embodiment therapy, where you can actually, in this one, he took pregnant women and had them become children. And you can see the small child's hand where the world's actually enlarged, so you feel like you're actually a child, and then had them being talked at by a mother, or there was both positive experience or negative experience, being scolded by a mother, and assessing their empathy. Lots of implications for this for psychiatric, or for mental health world, a very exciting area. So that's what I'll say for now. What we need is more people to get involved. So if anyone's interested either on the tech side, we talked a little bit about these pilot studies, and that's where you can kind of work with a lot of engineers and designers, but also patients to do studies related to that. Over here, I'm a big fan of symbols to just help me remember what I want to talk about. So I have a euro, and what I would say when I'm talking to any audience that's in Europe, you're uniquely, you have a unique advantage with the ability to work across maybe multiple hospitals or a whole country's network of hospitals. If over the course of your career, you get more involved with ability to do something at a very large scale, I recommend it, because we also need studies that look at things like health economics of something for a population or a whole society. How does digital health help? How does VR help at these scales? And you have a unique ability potentially to work at that level. We can do it in the US, but our healthcare system is a little bit structured differently, so it's a little bit more challenging. And maybe some of this evidence is going to have to come from our colleagues, across the pond. So I recommend, if you're interested, to get involved, and you can always reach out if you have any questions or want to find ways to collaborate.
All right. Thank you so much, Dr. Birckhead, for that wonderful presentation. And my apologies also for earlier mispronouncing your name.
No worries, no worries.
Yes. All right. So I am sure that that will most definitely lead to a multifaceted discussion later on in the Q&A. And to our audience members, please remember to add any questions that you have to that feature. I believe my colleague also just added a link to Dr. Birckhead's podcast. So like I said earlier, be sure to subscribe. Now we will move on to Jan Fossat. And let me just bring up there. Oh, Fossat, excuse me. There you are. So Jan Fossat is the principal investigator and head of the Applied Science Research Lab at Klick Health. Jan first worked within the fields of pharmacology and biochemistry research at the Université Côte d'Azur in the south of France. However, he soon found a way to escape the dreadful sandy beaches of Nice for the snowy streets of Toronto, where he co-founded a digital health agency. Jan's overarching goal is improving patient outcomes, and he uses evidence-based methodologies to do it. For example, at Klick, Jan developed the first tele-empathy device to capture and transmit the tremors of a Parkinson's patient to their caregiver, which as a granddaughter of a former Parkinson's patient, I find simply astounding. Jan is currently running multiple studies that focus not just on communication between humans and robots, but comprehension between humans and robots, specifically within medical contexts. He has been published in several medical journals, and we're so excited to have him here with us today. Jan, you may take it away.
Thank you. So I'm going to share my screen. There we go. And go. Slideshow. There we go. So I'm going to talk to you about extended reality for healthcare, and I put extended instead of virtual because the boundaries sometimes are a little blurry. So I will talk about anything to do with modification of reality. So virtual reality or XR is an incredible technology. Obviously, you know that since you're at this meeting, listening to me talking about this. It's a fantastic technology. It's probably one of the most transformative and most exciting tech that has come out in the past many years. But, and this is my provocative statement, technology is not the answer. I've worked in medical innovation and digital technology innovation for healthcare for a long time. And one of the traps that we face in my industry is focusing too much on the technology. Technology is a tool, it's not the answer. We need something to answer first. Just like a mechanic would never say, well, let's see what I can do with a screwdriver. They would probably ask you what's wrong with your car and then pick the right tool. This is the same. We have to start not with the technology, but with an actual problem. The problem to solve in healthcare is easy to find, and then develop a hypothesis, choose the right technology, develop prototypes, validate through various trials, and if it works, deploy it. So it's really simple, and it seems obvious, but one of my job is also to vet startups for our ventures group, and I see a whole lot of startup companies that start with really cool technology and a very ill-defined problem, and usually they don't go very far. So it's a good reminder. So is healthcare a good match for virtual reality? Definitely, it definitely is, because first of all, it's a problem-rich environment. My wife is a nurse, works in a hospital in the operating room, and if I ask her, hey, is there anything that you think could be improved? I better sit down because that would take a while. It's a really easy place to find problems. Healthcare is also a late adopter of technology. You never see the first Apple Watch or the first virtual reality headset or any sort of new tech being adopted immediately in healthcare. And that's good, because by the time it would be deployed, it would become obsolete because the next version 6 months later is so much better than you wouldn't want to use it. So being a late adopter in the context of very fast evolving technology like VR is good. It's also human-centered. Healthcare is all about human. This is healthcare for people. We're not talking about manufacturing or anything else like that. And virtual reality is a human-centered technology. It's all about changing your reality as a person. So perfect match. The roles of VR were covered by Brandon earlier. So as a reminder, there's diagnostic, education and communication, therapy, and the practice of medicine. And the practice of medicine is just emerging. It could be anything from a vein finder. I'm working on a project right now, which is like a vein finder that allows you to see the veins through the skin, or something as fancy as a headset that shows a surgeon the inside of a patient while they're looking at a patient. You know, there's a whole range of practice improvement. So I'm going to show you two projects that are healthcare virtual reality types. The first one is Health Voyager. And like I mentioned earlier, I needed a problem to solve. And the problem is communication with patients who have Crohn's or colitis, IBD patients, communication of the findings of a colonoscopy. When you have Crohn's, one of the routine things that will happen to you as a patient is to get colonoscopy and then meet with your doctor that will explain the findings. The standard of care, the tool that is used to communicate those findings is what you see on screen. It's usually a page that is generated by the EMR system, the electronic medical record, and it has a bunch of pictures that were taken by the scope, and they're difficult to comprehend for a patient. You have to be, you have to be medically trained to actually know what you're looking at. It's also kind of yucky. Nobody really wants to see the inside of their intestine, and it's just not patient friendly. So this leads to disengagement from the patient. It leads to lack of comprehension, lack of satisfaction. It's generally not a good experience. Who were the user we wanted to target for this project? It was children. We wanted to work with pediatric IBD, Crohn's, and colitis patients because the problem with them is exacerbated. Children don't have medical knowledge because they're too young, they haven't studied it. They don't really know which side their appendix is, where is the terminal ileum, if it hurts this way or this way, what does it mean? Their general ability to understand, comprehend, and communicate what's happening with their GI is very limited. So it was the perfect target. Our inspiration was the fact that some physicians already use technology that goes beyond the image, the screen grab from the scope. One doctor I met who started this project with us was using an iPad app that has basic drawings of anatomy like you see here, and he would draw on top of it to say, hey, this is where the scope is going, or this is where we found irritation. It's simple, but it was already communicating the information at a level that the patient liked more. In terms of choosing a technology, now that we had a good problem and a general direction towards solving it, we wanted engagement, comprehension, and satisfaction. And we're like, hey, you know what's perfect for that? Virtual reality. It will fully engage you because it blocks out the outside. It's very enjoyable for children, and it's very good at communicating complex things. If it's good enough to train a surgeon, it's probably good enough to show a child what happened through a scope procedure. So we created Health Voyager, and this was a collaboration between my team in Toronto at Klick Labs and the team at Boston Children led by Michael Doctor, who was the clinical side and was the technology side. So we had to create something that was not just a cool VR app. It had to fit within the workflow of clinicians. And the workflow in hospitals is fairly rigid. You can't really change a lot of things. It has to connect to the EMR. It cannot take a lot of time. There's all kinds of constraints that emerge once you start testing. So the first aspect of the project was we had to create an interface for the doctor side that allows them to enter the result of a scope procedure. And this is what we ended up with after many iterations. We had a time limit of 2 minutes. In 2 minutes, you have to run the EMR, select a patient, choose the scope procedure, lower or upper GI, and then enter all the results. And as you can see in that interface here, there's no drag, there's no pull down menu. We found that doctors really don't like pull down menus. It's just drag and drop. So you click on lower GI region, you get that symbolic drawing of the intestine, and then it's drag and drop. On the right side of the screen where it says discrete, we have polyp, ulcer, mucus, and so on. If you find a polyp through your scope, you just drag the polyp icon, drag it over the intestine, and it will just snap to one of those little dots. It's based on level builders in video game that allow you to build video game level very quickly. This is the same UI, it's very simple, and we did manage to get the whole thing done in 2 minutes. Once you're done, you save changes and it generates a QR code. This is how the information is transmitted to the patient. On the patient side, we have an app that ingests the QR code and then generates a custom 3D version of the intestine. And because it's for children, we created an avatar. The UI requirement for children are completely different from physician. So we have an avatar builder that allows the kids to feel more attached and personally linked to the app, even though it has no medical relevance, like the visualization would be the same, but it just creates that connection. And once the child is in the app, this is what they see. They have scanned the QR code, they created an avatar. This is Billy here. You can now travel through a virtual version of your GI tract as a patient. And you can travel up and down, you can choose different sections, you can find out where things were abnormal. For example, on the location map on the right, when there's a little red dot, it means that there was a clinical finding. And this is both really easy to navigate. The kids learn how to use it pretty much instantly. We don't need to teach them anything. And it's non-threatening. This is quite different from a glossy, wet image taken from a scope. They know it's not really there inside. It's kind of like looking at a map as opposed to a satellite image. The satellite image has almost too much detail. It's hard to decipher. And whereas the map is nice and neat, this is the map version of your GI. It has that simplified visualization where everything important is here, but everything unnecessary is not here. We've done additional little tweaks, for example, to help children. If you see the lumen on the left here, down the intestine, it's whitish light at the end. On a real scope procedure, it gets dark. The light comes from the scope, which means the farther down you look, the darker it is, and that's kind of scary and threatening. So here we put a light that's always away on the horizon. You don't see the light, but it gets darker when you look down, and that created more engagement, and the children are more likely to travel down to see what's over there. So this is all nice and it's cool tech, but does it work? Well, we had to do a randomized control trial because we know that's pretty much the only way to know if it truly works. We can't fall in love with our tech. So we did one. And the way our measurement was based on Lay's cognitive model, which is something that was published in the 80s. It shows that you improve understanding on patients, then you improve recall. And if you improve both understanding and recall, you increase satisfaction. And if you have all of these increased, you increase adherence to treatment. And adherence is very important, especially with pediatric patients who may not adhere to their treatment very well. So that's what we measured. We couldn't measure adherence because that takes too long. So we measured the other three as surrogates. And it worked. If not, I wouldn't use it in a case study. It worked really well. We published a couple of papers on that. We patented the technology. And as you can see by the blue bar being much higher than the yellow bar, we had much improved recall and comprehension and satisfaction. So why is this important? Not just or not only because it was a cool application of cool technology. It was important because we had a real problem with real people, with patients, with children, and that we nudged it a bit towards improved. We didn't solve everything, we just improved their condition. We improved their feeling, how they feel when they meet with the doctor after a procedure. This little girl in particular, I met with her many times. She was very shy, very afraid of talking about her condition. She doesn't want to be a condition. She's a child. She wants to be a person. And once we showed her, and once she helped us in the development, she became much more open. She realized that this wasn't so bad, and this was something she could talk about. Obviously, the condition is still here, but she felt much more open and much less ashamed of talking about her condition. And I'm now going to show you, I have a 2-minute video that shows the whole system in action. So hopefully I get the audio coming across. So this was virtual reality because we had a little clip-on that fits on the phone and it shows you stereoscopic 3D on the phone. You could also use it without the clip-on, just holding the phone around, and it's room scale VR, which works well in some cases because some people may have motion sickness using the virtual reality. But it's not always, VR doesn't have to be cool headsets. It can be other things. It can be augmented reality, extended reality. It's any sort of technology that overlays some sort of synthetic piece of information on top of your natural reality. And if we take that thought to the extreme, that thing in your car that beeps when you're about to back up into something else, that's augmented reality. That is augmenting my sensory experience of parking my car with an additional sense, an additional feeling, an additional piece of information. There's no goggles, it's audible, but that's also augmented reality. So with this in mind, we're like, how can we augment reality of people without necessarily doing 3D goggles? What is it that needs to be augmented? And one sense that's very hard to transmit is empathy. That was mentioned a bit earlier. We wanted to see if we could transmit the feeling, the sensory experience of being a patient with Parkinson's disease to someone who doesn't have Parkinson, and then quantify the improvement of empathy, because empathy is obviously very important. Lots of research shows that physicians who have higher level of empathy have patients who do better in their treatment, regardless of the treatment or their skills as a doctor or the kind of intervention. Empathy helps the patient. So we wanted to see if technology could help with that. And I'm going to
for the longest time we were in the same class in school and everything, same age, we're going through the same stuff all the time. Same friends, and like to go to the same places and do the same things. When we look back at old photos, we're not sure who's who. Not so much now. It's like not being in control of your own body. It's like something else is controlling you and trying to keep you from doing what you want to do. I'd like to feel the sensation and try and grapple with sort of everyday tasks and see what that's like, what it's like for Jim. Oh, there we go.
Do I feel something? Look at my hand. Look at my hand.
It's like I've lost complete control of my arm. You look like me.
Exactly.
Having felt it, I really kind of. I'm not sure how to describe it. It's the first time I've ever seen my tremor in somebody else. I want everyone to be able to feel that. Nurses and neurosurgeons could experience it in almost real time, and I think it will be a game changer for them.
So I wanted to show you this, first of all, because it's a project I'm very proud of, but also to sort of expand the vision of what virtual reality is. To me, this is virtual or augmented reality. We took the reality of Jim's wife or Jim's brother and changed it, at least for a while, until we turned that switch off, and added a layer to it that was not visual. In this case, it was perceptual. It was almost like a digital synesthesia. We added a sense to them, which is the sense of feeling what it's like to have a disease. And we increased their empathy. We did a bunch of studies on this, measured that the empathy measurement goes up significantly after about 7 minutes of doing exercise with this. And then sadly, it decays over time. We did a longitudinal study, but empathy slowly decays. So it's like you need a booster shot once in a while. Going back to my comment about technology, not starting with technology. In this case, we didn't even have a technology in mind. It did not exist. Once we figured out what we wanted to do, which is measure tremors and play it back in somebody else, we had to create the technology. So we made proof of concept with Arduino, ended up making our own circuit board, creating a series of devices, got it approved as an investigational device to run studies. But the technology shouldn't be the starting point. Once again, it's really what do you want to do, and then find the right tech. Yeah, published a few things on that. So as a closing thoughts, I think it's the fact that this is incredible technology. Virtual reality is fantastic. It's literally the closest thing to the holodeck in Star Trek, but it's the beginning of some sort of crazy exponential curve. We're just at the beginning. Things are getting so much better that at some point we won't even know where the boundary is between the digital reality and the traditional reality. So it's so exciting that we have to take a step back and focus on what it's going to be like tomorrow. Don't even try to solve with what you have in your hands right now. Try to solve the problem of tomorrow. Try to imagine what it's like in a year or 2 years or 3 years from now, when the technology will be so much better than it already is, so pervasive. Like, it could be a contact lens. You don't need that giant headset anymore. Maybe just a contact lens that connects to my phone, and I don't have a screen on my phone anymore. This is not science fiction. It would actually happen before I retire, I'm sure of it. So it's an incredible technology. It's moving fast, and it would probably transform medicine, or a good chunk of it, in the future. Thank you.
Wow, that is absolutely astonishing. I'm not going to lie, I got a little bit misty-eyed during the video with Jim and his brother, just thinking about the people in my own life. And I can imagine that some people in our audience absolutely felt the same way. Yeah, so I would thank you very much. Absolutely. Could I get Dr. Birckhead to come back on the screen, please? Hello, hello. All right, so we have about 15 minutes for Q&A, and we do have a couple that have just popped up, but I'd actually like to start with one that is for both of you. So what are some of the hurdles you have or could encounter when it comes to actually implementing VR technology within hospitals? What are some of your biggest challenges? I'm imagining that there are multitudes, but if you could name maybe your top two.
Brandon, you want to start?
Sure. I can think of two. I'll start with the hardest one. Would be if there's not, every hospital has different landscape for their support from leadership and interactions with leadership. So within the hospital, if I've seen situations maybe where if leadership maybe is not aligned or as interested in maybe what you might be wanting to implement, it can be quite challenging. The inverse of that is I've seen it where if a chair or anyone is really interested, it happens like lightning fast, and it's awesome. So I would say trying to align or best connect is a great one. The other one would be from a practical standpoint is that putting this in the clinic is very challenging because of the high volume pace. It's partly why, honestly, we started doing at-home VR. I did at-home VR way before the pandemic. It worked out, sadly, because the pandemic happened and we needed to do a remote clinical trial. But back in 2018, 2019, I did it because I pushed for us to move in that direction because I had 5 minutes to onboard a patient to do VR clinical trial. So I was like, I'd rather just do this on the phone and just mail it to their house. And we did. And so sometimes necessity, I move things around, but if you can get the right patient flow, maybe get the right staff, again, to be invested in it, then you can find ways to make it work within the clinical flow, but you just have to work at it. So yeah.
Okay, so initially it's both a hearts and minds type decision, and then also actually getting people to use the technology. You had mentioned earlier in your talk also that you were personally onboarding sometimes octogenarians with using your technology. Do you think that will change maybe once a younger generation sort of more familiar with that technology comes in and is a little bit more familiar?
Yeah. Oh, yeah. Anyone under the age of 60, it's pretty easy to onboard them. I mean, there's another study we did where we didn't even call people. So that last study that I worked on with the startup, I mean, again, it was individuals that have a Facebook account. So if you're in your 60s and you have a Facebook account, you're fairly tech savvy. And so they did it all completely without any, just remote instructions. So yeah, definitely this is rapidly changing. Just in 10 years, I'm sure it will be a different story.
And Jan, what about you?
So challenges to implementation of those tech are obviously multiple. There's hospital IT, which are all a bit different and all have their quirkiness and are generally not really happy if I say, hey, I'm going to install a new piece of tech that you now have to support. There's financial, who's going to pay for it? And this is universal, regardless of the reimbursement model. I'm in Canada, but a lot of our work is in the US, very different way of funding healthcare, but it's the same problem. The physician wants it, the patient wants it, but the person who signed the check doesn't really care for it or doesn't like to sign checks very much. So that's a huge problem. And the last part is workflow. Very little time is free in a hospital. Everybody's busy from start to finish. Every minute of everyone's time is accounted for. So when I add something that says, hey, 2 minutes, you can do this, they don't have that 2 minutes. So we need to remove something from the workflow, but that's really how this works. So these are not impossible challenges, but they are real, and it takes a lot of work.
Mm-hmm. Yeah, I can imagine that. I think on the technology sides, a lot of hospitals still use pagers, which, I mean, that's an older technology to be certain, but and yes, and not only that, but to take 2 minutes out of a day, we're not even considering the amount of training that might be needed in order to actually use this technology in the first place. So yeah, excellent. Okay, so another question for this one's for Jan. So what are some of the patients or institutional reactions you've received from your Parkinson's tele-empathy project, aside from what we've just witnessed with Jim and his brother?
So the reaction is almost invariably positive, like people want it. So the first reaction I get is, can I buy one? A lot of people want to buy one, but it's not it's an investigational device, so we can use them in the context of a study, but I can't actually sell them. I tried to apply for FDA, 510K, something. We went halfway through the process. It was really complicated. So I can't sell them. But that's the first reaction. It's typically people who know someone who has Parkinson who want to try it. They want to experience it. We've also had a reaction of people who want to do interesting things with them beyond the empathy transmission, which is the simulation of condition. So if we step back, if I can show you what it's like to have Parkinson, let's say untreated, maybe I can show you what it's like your tremors or somebody else's tremor when they take this medication or that medication. Because if we digitize the tremor of someone on and off medication or on and off period, then we can create an algorithm that represents what the medication does. And possibly we could simulate a treatment on real data input. So there's some interesting research avenue that are going there that need some funding and some time, but that's some of the reactions we've had.
Interesting, especially because earlier you also mentioned that there was an empathy spike, but then it tended to taper off. So would you imagine that having these in Parkinson's patients' home would kind of allow that spike to plateau a little bit more, if it were possible?
So it's interesting, when we measure the longitudinal effect, that was in medical students. We did not measure in home caregivers. So the med students' empathy decayed over time after 1 year. And there's a bit of a relationship to what the base empathy was and how high we got it. But generally, they all decay. That's but for the home caregiver, for example, Jim's wife, whose empathy was changed a lot. It's not like she had no empathy, it's her husband, but somehow she got a new color added to it. She came to us weeks after the one of the experiment and said, you know what, I would get frustrated when he tries to cook. He likes to cook, and I would get frustrated with how long it takes him to make a sandwich, for example. And having tried it and just putting that straw in a little juice cube opened up her mind even more. And she didn't have a lack of empathy, she just got a bigger boost. And I don't think that would decay. That would be my feeling, is that's here to stay.
I believe that. That's wonderful. Okay, so a question for Dr. Birckhead. So what are your recommendations when doing a VR study, including the input of the target, including the input of the target population?
Yeah, so for those, it's going to be what we call a qualitative study. So it's mostly just wrapped around either a one-on-one interview or a study group or a focus group that probably up to 12 people. I wouldn't recommend more than that. And to definitely collaborate with a qualitative researcher, because how you design the interview guide will dictate the data that you get. And you really need to have that experience to broaden the question stems. And then you need to always have it recorded, always have it transcribed, because if you don't transcribe it or have it recorded, you're going to lose lots of data. And then also that same qualitative researcher to help you with the analysis. There's a lot of different ways to look at qualitative data, and you need to be able to stick with something that's, you know, validated or makes conceptual sense. And then I usually recommend somewhere between 3 rounds or 4 rounds of iterations. So you just come in, get the information, go make a storyboard, come back with the storyboard, iterate again. That's when the designers and developers get involved. Use the storyboard to make the VR, get feedback again. And then if there's side effects or anything, you know, you can tailor it one more time. That's why I think you may even do 4 rounds, but at least 3 or 4 rounds of iteration. Yeah. And I have a paper on that. You can just look up that VR core and then the study, and you have a lot more details.
Interesting. Okay. Apologize for the Simons in the background. So a question that popped up for both of you into our Q&A box was related to the access to this type of technology in resource limited areas around the world. Our attendees specifically mentioned areas here in the United States, like Native American reservations or the Appalachian community. So what would you say to getting VR technology into more non-privileged areas?
So here I would mention that it doesn't have to be expensive. If you saw in my video, I'm trying to see if I have one here, but you can make those little clips that fit on your phone, and they cost like $1 or $2. It's one thing, they cost $10 if you buy them on Amazon, but $1 if you buy them on AliExpress and you buy a case of 5,000. So it doesn't have to be expensive. I think that the core component can be a cell phone, and right now, almost everyone has a cell phone. So it doesn't necessarily have to be the best technology. It just has to be good enough and affordable enough to do the job. So and I don't know if it's the main factor that would limit something to be deployed is the cost of tech now.
Okay. Because that's a little bit interesting to me, because one of our other questions for both of you is, at what point will VR technology become so widespread that it's taught in medical schools as an essential tool in contributing to a patient's positive result? But at the same time, Jan, earlier you said that VR is not the solution. It is, you need a problem before you can have a solution. So in using VR technology, how exactly does that meld? We want to distribute it really widespread, but at the same time, there needs to be, as Jan said earlier, a problem that we focus on specifically. So how does that mesh in terms of having it be essential in teaching hospitals, but and at the same time, it needing to be very patient specific?
Education. There are medical schools that are using it for like anatomy, and there's definitely some examples of that. University of Colorado, University of San Francisco, and a few others. The patient specificness of it that's a good point. I definitely think that the sim centers these hospitals are purchasing a lot of programs to try to create tailored experiences for things like empathy for patients, and that's. So there is a lot of different types of programs that would need customization, but I definitely think there's been a lot of great work by the sim centers purchasing lots of different types of content from startups. But Jan, this is a bit your area, so I don't know if you have thoughts on this too.
Yeah, I would imagine, when is it going to be taught in school is when you don't even realize it's being taught anymore. So when the technology becomes commoditized and it's not about the VR anymore, but it's about the application. I think a lot of treatments or interventions in medicine are focused on, we do this and this happens. The underlying biochemistry or electronic or engineering aspect is immaterial. That's not what practicing medicine is about. And I think this is when the technology has matured, when it goes behind the scenes. It shouldn't be about VR. It should be about, this intervention helps patient this way or helps communicating that way. It happens to use VR. Just like if you still use a fax machine, you don't really need to know how it encodes the data. You just need to know that, hey, that paper goes somewhere else. So I think that would be when it stops being cool and when it becomes truly useful. It's that slope of enlightenment.
Yeah, I like that. And although I will say it's probably been a decade or more since I've used a fax machine.
Still in Canada.
There you go. Potentially deceptively simple question. What are some side effects of VR?
Yeah, I guess, so that I worked on a review paper for this, and in general, the most common VR side effect would be temporary mild nausea in the population that can resolve quickly after taking off the headset. As far as the incidence, it's not totally known because of the wide variety and amount of changes in technologies. I predict that if you look at a study and they're excluding motion sickness, you're going to see in about under 10% incidence of a VR side effect. If you don't exclude motion sickness, then you can be as high as like 25%. It can be, it can be somewhat mitigated by how you design the program and the type of technology you use. There's several other signs and symptoms that can come, things like, headache, heat around the eyes or eye strain, potentially vertigo, or just, heaviness, feeling a sense of heaviness in the neck. But again, all those are in kind of short-term temporary. And then there are a few long-term, but very kind of a lower incidence, they call them after effects, but we don't see them a lot right now, and at least in the clinical trials. But yeah, I don't know if Jan, you might have more thoughts on, I haven't seen it often for the patients that have treated, I have seen nausea, but I haven't ever had to use like medication for any of the VR side effects in the last couple hundred patients. But what's your experience, Jan, with that?
Same, nausea or motion sickness happens once in a while. We've read a bit about this potential long-term side effect in pediatric, like kids around before 8 years old, I think, where if you spend a lot of time with that, you may end up being myopic. There's some development of the eye that happens, but that's if you're young and you spend a lot of time in VR, so probably unlikely. But I wanted to say some of the side effects are actually useful. So I was working on a project where we wanted to simulate what it's like to have, it's a seizure that starts with nausea and then blacking out. So we wanted to simulate that. And if you disrupt the synchronization between the visual input in a virtual headset and the inner ear, so we use a gyroscope. I mean, there's a gyroscope built in that knows where the set is moving, and it moves the video according to that. If you induce a tiny delay in here, it doesn't have to be long, like, a few, way under a second of delay, you generate a very strong nausea immediately. We can also create tunnel vision by literally just blacking out the outside. So you can make somebody feel what it's like to faint without them actually fainting. Now, the risk is they would actually get sick, but it's just to say that we're hacking, in a sense, we're hacking the senses, and we can play with those parameters. So in some rare case, this might be useful. The heat is a big problem, but that's disappearing as the headset becomes smaller. When we worked with the first or second generation equipment, it was big, there's screens, there's like that gasket, you end up sweating like crazy. It's not very comfortable. That's improving.
Interesting. All right, so we're just about out of time, but I think people will forgive us if we go over just a little bit, because I have a final question for the two of you. And it's, again, probably another deceptively simple one. In one sentence or more, let's be real, what is it about virtual reality that drew you in, and what is it that is making you stay?
Brandon, do you want to start?
Yeah, I would say what drew me in was that sense of presence or immersion. My first day with VR, I was scared by a T-Rex and actually fell in a fetal position because I'd never been terrified by a T-Rex like that. And using that for healthcare applications was an exciting thing. What keeps me in VR is I didn't know I needed an outlet for creativity within healthcare. If I didn't have an outlet for creativity, healthcare for me just doesn't feel, I guess it's hard for me to motivate as much. And so I think VR allows for a nice creative outlook for wanting to help patients.
And potentially opens, the medical field to people who might not initially think that they, are interested in medicine.
Yeah.
But, and Jan?
For me, probably kind of the same. What drew me into VR is trying it and being so astonished as how effective this was. I was at Exponential Medicine, the conference, and I tried this thing where you you're on a window cleaning little cart that trolleys up the side of a building. So I'm standing on a carpet in a boardroom, but I'm wearing this thing that makes it look like I'm flying up the side of a building to the 150th floor. And then the railing falls off and I'm swinging in the air and I fell down. Knowing full well, I'm conscious, I know I'm standing on carpet, I shouldn't, but it was such an intense feeling. I was like, this is such a powerful tool. We can push stuff into people's brains so effectively with that. It became, and the thing that's making me stay is realizing how crude and primitive the technology is. I know where it can go. I've seen Star Trek. It's going to be the holodeck, except I won't even need the room. So we kind of know where we want it to be. We know that the technology is so crude and yet so amazing. I can't wait to see where it goes. That's
absolutely incredible. Oh my goodness. Well, thank you both so much for your time and your brilliant insights. This has just been an absolutely fantastic conversation. And yes, to all of our attendees who've enjoyed listening to this discussion, we would like to thank you for your time and attention. We also wanted to extend our warmest gratitude to our partners at HESAV and of course the Canton de Vaud. And I personally would like to thank my Swissnex team members, James Moore, as well as Jonas Brunschwig for making this happen. So thank you so much and have a wonderful rest of your day. This has been a very wonderful conversation to spend the rest of the day with.
Thank you.
All right.
Thank you.
Bye, everyone.
Bye-bye.